First of all, I would like to thank you, Dr. Dev, for all you've done in southern India as someone from southern India. I always get my glasses in India. I don't buy them here. Too expensive as a postdoc to buy stuff here. Anyway, good morning, everyone. Today, I'll be talking about what we feel are opportunities in laser intravascular interventions. Some of this work is partly funded by the ASLMS research grant in 22-23. And the IP belongs to the Clayton Foundation for Research. I'll give you a brief outline here where I try to introduce the clinical problem of calcium or calcified arteries, and two particular cases where there are partial occlusions in the arteries versus complete occlusions, followed by current treatment methodologies for this problem, followed by the potential for opportunities of using lasers for addressing this, and two specific cases. One is for lithotripsy, and the other is crossing completely occluded lesions. To start off with the problem of a calcified artery, here we show an example of a CT scan where you can clearly see the calcium all the way from the femoral on the bottom left, all the bright spots where the yellow arrows are pointing, all the way from the femoral to the heart, where the calcium significantly reduces the lumen area, as you can see on the right, where lumen areas are pointed out. It significantly decreases the lumen area, increasing it in difficulty to deliver devices to the heart through PCI. PCI is where devices are introduced through the femoral artery and put in all the way into the heart. So for them to reach the heart, they have to cross all these tight locations in order to reach the heart and provide therapy. So this difficulty in device delivery can damage, for example, a stent. If you're trying to deliver a stent to the heart, it can get pre-damaged itself while trying to cross these tight lesions. Worst case, of course, is major adverse cardiac event, MACE. So this is an example of that. So on the left, you can see like calcium in coronary arteries poses a significant challenge for completing PCI or completing therapy. And calcium has been independently associated with higher cases of MACE versus treating lesions that are not calcified. So given this significant challenge, there are several devices that have been proposed over the past few decades. And there are two subsets of these. One is for intravascular lithotripsy. Well, I'm not doing that. I don't know what that is. The other is for complete occlusions. So for intravascular lithotripsy, let me see if I can go to that. So there are two different treatment approaches. One, they can be broadly classified into two different types. One is ablative, the other is lithotripsy. The ablative, as you can see in the videos on the left, I'll try to play them again if I can, is where there is removal of plaque, and you're essentially increasing the lumen area and modifying the calcium superficially by increasing the lumen area. So when you increase the lumen area, you get higher compliance. But as you can see, there's debris that's coming off here, so debris management becomes important. And with some of the laser approaches, thermal damage to the wall becomes important as well. However, on the lithotripsy approach, the mechanism of action is ultrasonic pressures that are sent into the calcium, fracturing it at high amplitude pressure waves. And as you can see, sound travels deeper. So you're able to affect radially deeper calcium. The debris is self-contained in the plaque, so there is no dislodging of the debris, and there is minimal to no thermal damage. The concept of lithotripsy was first introduced in pulverizing kidney stones from the outside, called extracorporeal lithotripsy, where they induce shock waves into the kidney stones without causing injury to healthy organs. Similar to that, this is similar to that in that you're delivering shock waves radially deep into the calcium while leaving the soft tissue intact. Even with these advantages, let me see if I can advance here. Yeah. Even with these advantages, the approach uses electrical discharge, which is a high voltage spark inside the balloon that causes a vapor bubble. As you can imagine, high voltage shock can also cause ventricular pacing in the heart. So that's one limitation. The other is being able to deliver such high energy pulses or high peak power energy pulses. You have a minimum size of the device. So it has to be, the lesion has to be open at least 1.2 millimeters. On average, on the lower side, they can go down to like 0.8 millimeters. The occlusion, the partial occlusion can be as small as 0.8 millimeters, where you have to use rotational atherectomy, which is the mechanical device I showed, where you have to cut the plaque in order to get the device in there, which is not preferred, which is what trying to avoid. And given that they're the only approved device, I believe, it's pretty expensive per catheter, and I believe it's like $4,000 or something. Here in lies the opportunity for lasers, we believe. In comparison to the approaches of high electric field discharge, laser lithotripsy originally has been used in kidney stones for decades for cutting or fracturing calcium or calcified kidney stones. Lasers provide specialized pulses in small optical fibers. Like you can deliver very high amounts of energy in a very small form factor. A brief comparison of the two methods can be seen in the table here. One, there's minimal electrical fields associated with the laser approach. The profile of the lithotripsy fibers, like I said, can be really small. And the other limitation on the electrical approach is that it has a limited number of attempts. After 80 shots, the catheter cannot be used again. That limitation is not there for fibers, which can go beyond 150 shots. In addition to that, given the small form factor, one can foresee a case where you can incorporate intravascular imaging, so you can get live imaging during the procedure as well. We show the two cases. One is the spark electric discharge lithotripsy. You can see here there's an initial spark in the beginning causing a vapor bubble to expand, and then a collapse of which sends a shock wave. Similar to that, the laser approach also is able to provide a similar sort of a mechanism generating shock waves as well as generating strong enough pressure waves at the collapse of the vapor bubble. As you can see here, in a smaller form factor, because the fiber here is only 200 microns compared to about a millimeter in the shockwave case. So we took this and completed a benchtop validation in plaster of Paris phantoms, which mimic completely radial calcium cases with a fiber. And you can see after a few shots, there's like cracks that form in the calcium, and then it like dislodges. Then we took this to ex vivo human arteries and showed that you can get an increase in lumen area, which corresponds to a higher compliance as well in 14 arteries that were from donated hearts. So a summary of this part of the talk would be that LIVL, which is what we call laser IVL, produces similar pressures compared to electrical IVL. The choice of pulses is much limited in the electrical approach. You can only go one shot at a time versus the laser approach where that limitation doesn't exist, in addition to it being a smaller form factor and has the capability of being incorporated with real-time imaging. So for the second part, it's what would you do for completely occluded lesions? So there's no way to get across it. So CTO, which is called a CTO. So CTOs are found in about 20% of the patients undergoing angiography. So there's about 2 million patients that undergo diagnostic angiography annually in the US. Typically, they consist of a completely calcified proximal cap and a more distal fibrous region. Once they're found, it's critical to restore the blood flow once they're found in the angiography. Again, for current treatment methodology, the most common or the most well-known is bypass surgery, where you just bypass the artery that's completely occluded. The other is medication, the third being PCI, which is what I mentioned before, where you try to deliver devices into the heart and provide a therapy. CABG, or bypass surgery, typically involves about a 3-day hospital stay with reduced activity and costs about $50,000. And they typically use venous grafts, which become occluded within the 10 years. Medical therapy only provides temporary relief versus PCI, which is more longer lasting. Despite these advantages, only a select few people are able to do these procedures. This may be explained by looking at how the current procedure is done. So a wire is looped and purposefully advanced past the CTO in a space between the plaque and the outer vessel wall, as you can see here on the top right. And then advance past the CTO. After advancing, the wire is pushed back into the lumen, and a stent is placed in the wall to expand and re-induce flow in the artery. Because safely redirecting the wire into the true lumen is a difficult step, knuckle wires or specialized wires are used for this purpose. So as you can imagine, like, doing this can cause a lot of complications, and there's a list of complications on the left here. So we believe the solution to this is like crossing true lumen. There are 3 limitations as to why it's difficult to do this. They boil down to the ability to cut calcified bone-like proximal cap of a CTO using nimble wires, because they have to be nimble in order to be able to reach these tight locations. So a wire or a catheter has to be small enough to traverse the tortuous arterial network and yet be able to transduce sufficient energy to cut hard calcific regions. Of all the energy methodologies out there, one can imagine like the fiber being the smallest and the most nimble, being able to deliver the highest amount of energy. There have been many devices in this actually that can be classified broadly into 3 energy types: mechanical, sonic, and optical. Mechanical is where it's like a drill bit at the tip of a catheter that's rotating into the plaque slowly. Second are sonic wires, which use dispersive materials that carry a pressure wave all the way to the tip of the wire that punches into the calcium. And finally, it's our approach, and Excimer is another example, but Excimer doesn't work well with calcified lesions. So this is just our benchtop test here using a real a CTO that we extracted from a donated human heart. And as you can see, the laser approach, you can play here, but it actually goes through it pretty quickly. Typically, these surgeries last about 1 or 2 hours, so if you can cross a little bit of a lesion at a time, that's sufficient in terms of speed. And I don't know why the video is not playing anymore. I apologize for that. So if we summarize the 3 energy modalities here, all of them have some possibility of injury. In terms of size, the mechanical tools are larger, as you can imagine, in order to transduce that amount of energy onto the tip of the catheter. The sonic and the laser approaches are smaller. Our approach uses a pulse laser with a fiber delivering the light on the distal side with cold spurts of saline or CO2 through an FDA-approved microcatheter, as you can see on the top right, which can flex in many different directions. This was, as you can kind of see in our animal model here, animal femoral model. In the X-ray, you can kind of see it flex left and right. being able to cross these tortuous networks. These are some of the histology results in our ex vivo case, where we cross these donated human arteries, which are calcified across the lesion with minimal thermal injury. I'll not go into our in vivo models and all the other results for time, but I'll just end with the opportunities for lasers for CTO crossing. We were able to demonstrate the ability of lasers to cross CTOs in ex vivo human arteries as well as in our femoral model. Our next steps are to evaluate this in a coronary model, which is closer to the human in a big coronary model, and demonstrate image guidance methodologies for this. Traditionally, in the past, lasers have been used for angioplasty. In the 90s, Holmium-YAG was first attempted to cross these partially occluded lesions to cut the plaque. So a natural question would be, why now? Why? People have tried this in the 1990s with flash lamp pump lasers. And I'll be careful about saying anything bad about flash lamp pump lasers with Jinsey in the room, so they're great. They work great. Anyway, so over the past few decades, like you can see from the 90s to now, the brilliance of some of these newer semiconductor lasers has gone up 10x every 7 years. So they're becoming brighter every 7 years. So the graph compares the brightness of a semiconductor laser as a function of time. You can see, it kind of follows the Moore's law of transistors per chip on a log-log scale, on a log linear scale. And at the same time, more importantly, the cost of the laser per bright watt has been going down for 10 times every 7 years. So the cost of these semiconductor lasers has gone down about 10x every 7 years. So in a few years, one can expect these costs of these devices to be comparable to that of mechanical or electrical approaches, which have been traditionally cheaper. So we believe that given the size or the ability of optical fibers to transduce energy from one location to the other and deliver specialized pulses that can do both lithotripsy and cross lesions if the need be, there exists a heavy opportunity for lasers in intravascular interventions. With that, I would like to acknowledge my lab as well as Dr. Feldman's lab, who are our collaborators, and Dr. Milner for his guidance, and ASLMS for their research grant support in 2023, along with our other funding support from Clayton Foundation, SBIE, and the Beckman Laser Institute. Thank you.